listening to The Doctor's Corner with Dr. Kline and Janelle Elgaway.
Good evening and welcome to the Doctor's Corner with Dr. Kline. I'm your host, Janelle Elgaway. Welcome, Dr. Kline. How are you this evening?
Couldn't be better.
Great. If anyone wants to call in with a question for Dr. Kline, please do so at 415-915-2291. Also at 8/7 Central, guest Dr. Jeff Fuden will join us on Call Nation to talk about urine drug screens and much more. So if you have any questions for him, please call in as well. Dr. Kline, I was wondering something, because this whole reason why we even wanted to do this show was to answer questions of people or patients that were afraid to, or uncomfortable to ask their doctors. Did you always know that it was like that, that patients were afraid to ask you questions?
Yes, and I actually had a little protocol where the patients would start chatting with the office receptionist.
Oh, okay.
And the receptionist was kind of trained to draw people out, and then she would be diplomatic and say something like, well, you know, that's a good point. Why don't you ask Dr. Kline just straight away about that? And then people aren't fearful. You know, physicians give the people the impression that they're the boss. And it's paternalistic, and we need to get away from that. That patients, they always talk about patient-centered medicine.
Mm-hmm.
And what is patient-centered? It just means a good relationship between the doctor and the patient. And we're not just bulldogging people and telling them, here's what you take this, fill this prescription. You know, that people get a say. And one of the problems, certainly lately, is having a say in your pain issues. It's just awful.
Mm-hmm.
Nobody listens. Whatever, but hey, there's ways around it.
Right. Do a lot of doctors are they aware of this, or do you think the majority of them, you know, think that, you know, patients will come in and just be open and, you know, honest and not afraid to share things?
No, we're from a trade school. Medical school is nothing more than the same as learning to be a plumber or electrician. Mm-hmm. Or a car mechanic. You learn from your peers. You learn from other people. So we learn from our other doctors, and then we get all these bad habits, and it's time to change. Mm-hmm. One family practice I know invited their patients, whoever wanted to come, to a dinner once a month. And it was a time for the patients to say, you know, doc, if you did this, it'd be a little easier if you did that. And they worked out problems together. It was marvelous.
Oh, man.
So...
Have you ever invited patients over for dinner? Can you do that?
I didn't really have a large enough practice. I spent a lot of time with my patients, and we kind of had open communication. And my staff, most recently I worked with a nurse practitioner, and so people are more likely to relate to a nurse practitioner than they would me. So that was a good interface, but... you know, if I invited them over for donuts or something, I'm sure they'd all come. So,
well, if a donut, everybody has to be there then.
Yes, these are important food items, you know, and the health of Americans.
Right.
But we won't go there. So
that's another show. So last week we talked about diabetes. Is there anything in particular that creates an onset for diabetes to occur that you know?
Well, a lot of people, there's this old myth around that if you eat too much and get fat, you're going to get diabetes.
Mm-hmm.
Well, then they discovered there's a whole bunch of people that eat too much and get fat that do not have diabetes. And then they discovered, egad, you know, a lot of these diabetic folks are real skinny. I think that in researching this, it's not a real strong opinion. I think the metabolism being a little bit off causes the diabetes, causes the obesity, not the other way around. It's important every once in a while when we have these notions to do a 180 and flip it around and see if maybe it's the other way around. And I think in diabetes it is. Eating too much does not cause diabetes. Nothing causes diabetes except your genes.
Okay.
It's definitely an inherited thing, and they even are discovering some of the genes. It has the property of incomplete penetrance, which means if you have two blue-eyed people, you're going to have blue-eyed children, period. In other words, it's 100%. But these other funny diseases, like addiction and like diabetes, it may only be partial. And what that means is you may have a very strong history of diabetes, a whole bunch of people in the family with diabetes, and you don't get it. Mm-hmm. And vice versa, you may get diabetes and have nobody in the family with the disease.
Right.
But if you take it as a whole and look at it, you say, this is definitely running in families, sort of.
We have a question from YouTube. Stacy Fields wants to know, Dr. Kline, is there any chance I will not get diabetes since I have chronic pancreatitis? Why would she think she would get it with chronic pancreatitis?
A lot of people think they're tied together because the little diabetic, the little cells making insulin are in the pancreas, but they're kind of just visiting. They're just sort of sitting there. So even though it appears to be a relationship, no, you will not get diabetes. And now, very important, just because your blood sugar goes up does not mean you have diabetes.
Okay.
So
can diabetes be reversed?
No, because it's genetic.
Are they working on a way to be able to go in genetically and change that gene?
Yeah, the difference is type 1 diabetes and type 2 diabetes are totally different diseases, and they should never be thought of as the same disease.
Okay.
The type 1 diabetes that kids get is actually one of those funny autoimmune where your own cells start attacking the cells making the insulin, the beta cells, and they are working on that and trying to interfere with the abnormal immune response. But type 2 diabetes, if you really have it, cannot be reversed.
Well, and why do you say if you really have it? Do people sometimes think they do?
They make the diagnosis of diabetes based on blood sugar criteria.
Mm-hmm.
Well, that's like saying, well, if you have a temperature over 102, you have this particular illness. Generally that's true. Tuberculosis, for example, always classically had a low-grade fever, 101, 101.5. But that's not very precise. The blood sugar is really not very precise. We don't like as doctors to diagnose anything just based on laboratories or x-rays. Laboratories and x-rays are to confirm clinical diagnoses. And my current thinking is, although a lot of people are not on this same idea, the most common and easiest to see real diabetic marker is diabetic eye changes. Now, if you get your ophthalmologist or optometrist are fine. They look in your eye, they dilate your eye, which they kind of do anyway, and they'll see them right away. There's little tiny changes in your eye that may never amount to anything, but that's a signal you got the gene.
Oh, wow.
There's
Okay.
lots of people that go through life and they got these little signals. You can do a urine test also for albumin creatinine, it's called, ratio. Those two things, you can kind of confirm you really have the disease. It doesn't matter what your blood sugar is. And guess what? You can look in the back of somebody's eye and see classical diabetic changes and have a normal blood sugar. So there you go.
Who makes
blood sugar should never, ever be used to diagnose diabetes without a clinical finding.
Okay. So. What makes, where did they find the levels that if it's over on the charts that you are diabetic?
Yeah, these, and trying to track these down, believe it or not, it goes back to the 1950s, and they were pretty much made up.
Oh, wow. Okay.
They never compared it to the population like you normally would for lab studies. They made it up, and then they never checked. It just kind of got in the literature. And there are forces around that like to have more diagnoses of diabetes because it's big money. Sticking your finger, buying the strips, taking these horribly expensive drugs. It used to cost about $50 a month to treat your diabetes, your type 2 diabetes, and now it's up to $800 or $900 a month. I mean, it's just a feeding frenzy by the drug companies. It's just awful.
With diabetes 1, you have that from birth, right? And I mean, these are genetic, so of course you do. But what actually makes it onset that, or kicks it in that you actually start having issues and symptoms?
Well, if you don't go to any of these screenings, and your doctor doesn't check your blood sugar, you could just go along the rest of your life and probably nothing would happen.
Mm-hmm.
But as soon as the blood sugar is elevated over 125, which is ridiculous, then automatically you're classified. You're diagnosed by your lab study as having diabetes. So I can't tell people not to get blood tests. But when you get a blood test, the next step should be, okay, I need to go see my eye doctor and see if there's anything in my eye retina that indicates I have diabetes. If it's not there, I'll say, hey, why don't we just check this every year? People say if you intervene early and get these blood sugars down, that's not true.
Okay.
And there are reasons that it's not true, and it has to do with the studies that were done, and some studies that showed no difference were ignored. So it's kind of one of those conspiracy monthly things. So.
Okay, so when we have a test now that you can tell if you have a gene for breast cancer, why don't people get tested early on before symptoms and stuff for diabetes? And is there anything that you can do to make sure that you don't get it?
Good question. I don't know the answer to that.
Okay.
I have not heard about genetic screening. There certainly ought to be. But the main thing is, I think people ought to go to their eye doctor once a year anyway.
Mm-hmm.
And I go to an optometrist. I like optometrists. If you have a problem, they have somebody in the chute they can refer you to who's an eye surgeon, which is an ophthalmologist. Anyway, you go in for your yearly exam, and if they see something, they'll tell you. Hey, you got a tiny little bit of early diabetic changes in your eye, and then you have it, and so then most people just rush off to the diabetes team, that takes control of their life and tells them never to, eat cake, and because anytime your blood sugar goes up, you're going to make your eyes worse. But unfortunately, there was only one study done in 1998, the famous DCCT study, led out of the Mass General in Boston by David Nathan, who has crowned himself emperor of diabetes. But one study's not enough. You have to replicate the study. The Higgs boson.
No, I'm sorry. Go ahead.
The Higgs boson that was discovered, this physics thing, nuclear physics, and they announced it, and Higgs came up, and he got prizes and everything for it. They actually did not announce it until they had a replication. In science, almost 40% of studies done when they replicate them don't hold up. Wow. So the fact this study has never been replicated means, hey, it still sits on the shelf. It's interesting, but you're not going to change your practice based on an unreplicated study. I never have. And there's lots of articles in the New England Journal, for example, pumping up new drugs for diabetes and new drugs for everything, sponsored by the drug companies, good heavens. And so when I read those, okay, I need to see this replicated. When are you going to, as soon as you replicate it, I'll just kind of keep it over here on the shelf. And when the replication comes, I'll put the two together, and if they both match, then I'm more likely to make changes. But the diabetes control issue is way, way out of hand. There is an easier and kinder way to treat diabetes that will produce just as good a results, and that's basically de-emphasizing the blood sugar.
When you say diabetes is out of control, do you mean the amount of people that have it, or of how
Yeah,
it's...
good point. That's the treatment of diabetes,
Okay.
diagnosis of diabetes. The American Diabetes Association, you're going to go blind.
Mm-hmm.
Diabetes is the most common cause of blindness. Well, there's more diabetics. So therefore, blindness, even though very low frequency, way less than 1%, still has the largest number.
Okay.
So you see, that's dishonest. That's dishonesty in fundraisers. And they're basically fundraisers. They do sponsor a lot of good research with the money they raise, but their rating as a charity is not 4-star. Let's just leave it at that.
Okay.
So,
we have another question. Somebody says a friend that has chronic pancreatitis, they can't do anything for her. Is there a good treatment for this? I'm not. And then they say hypoglycemia. I'm not sure of the question.
hypoglycemia.
Yeah.
Well, hypoglycemia is tricky. You have to first make sure you're not making too much insulin, which can come from pancreatic disease. And it's very simple. You just measure your blood insulin level. You get a blood test.
Mm-hmm.
If you're making too much insulin, then they got to track down where the little cells are that are making too much and get rid of them. So that's a serious problem with pancreatitis. Chronic pancreatitis is a difficult to manage chronic disease, a long-term disease, and usually it's managed with pain control, because when they have these flares, it's just horribly painful. It's
Right.
just unimaginable.
Yeah. Yeah. I had it last year for 9 days, and I was in the hospital, and it was, I have all these other health issues too, but I've never had pain quite like that. It was horrible. Yeah.
It's awful.
Yeah. Yeah. We were talking earlier about addiction, and I was wondering about a gene that carries addiction. How could it hit? So I know it's genetic, but how can it jump over certain people within your family circle? So, like, say if my brother has it and I have the gene, how come I'm not addicted and he is?
Okay, that's the funny thing about genetics, kind of similar to the diabetes.
Mm-hmm.
There's different degrees of penetrance. So in other words, if there's a 70 degree of penetrance, that means 2 parents with the diabetic gene, you have a 70% chance of getting it. Well, you would think you would have a 100% chance.
Right.
So that's the funny thing about genetics. You get this partial penetrance. A lot more, if you take a whole bunch of parents, both of which have diabetes,
Mm-hmm.
you're going to have, on average, a lot higher incidence of children with diabetes. But that doesn't mean in individual families, you could have everybody for 3 generations with diabetes, and the kids are fine.
Is it like that with every disease?
Excuse me?
Is it like that with every disease?
It's like that with most diseases that are genetic. It's funny, either your body is kind of taking care of these abnormal genes, or then you got 2 to deal with. If you've got a father with diabetes and you have a mother without, it's how the 2 are going to mix together. But yes, that's true. There's really very, very few diseases that are 100%. Sickle cell anemia is pretty close.
Mm-hmm.
You could pretty much guarantee that if you've got 2 carriers, you're going to get it. Tay-Sachs disease that Jewish folks have, same thing. And as I mentioned, eye color, that's not really a disease.
Right.
But, most are partial penetrant. Or they call them multifactorial or something. And you see, that's the silly thing. If I take a history from somebody and say, well, there's cancer in your family, then well, which ones are really genetic?
Right.
And if they are genetic, how much are they trans? And that's some questions that are usually asked in genetics clinics, which people rarely go to, but they really should
Mm-hmm.
if they have a genetic disease in their family, because it's not just about you. It's about your brothers and sisters and everybody who's having children, and then the children need to kind of know what their risks are for these various diseases. They're not real frequent, but they are around. Usually at the medical centers, have these genetics clinics, and you can sort of get a better idea.
Right. Does insurance cover those, or would you have to pay out of pocket?
They should. Yeah, I would think.
Yeah.
Yeah, if you've got a disease like Ehlers-Danlos that runs in families, maybe not with diabetes because it's not, like you said, it's not ready yet. But yeah, I would think the breast cancer gene, if it runs in families, there should be genetic counseling, and sometimes they do have special tests to find these genes, and then they can do their calculations and kind of give you risk factors and what you can do about it, how to detect it early.
We have another question from Danny Benton off of YouTube. Could you ask the doctor to explain receptor disorder disease?
Receptors are picture a basketball or a soccer ball in a little place where you fill it with air. That's a receptor on each cell. And the little needle that you put in to pump the air in is what's going to fill that little receptor. So in addiction disease, for example, the little receptor is called an opioid, a word I don't use very often, but now it's proper, opioid receptor for your own endorphins. Your own endorphins are closely related to all the narcotics. Your brain makes its own narcotic. And it fits into that little receptor, and when it does, then it causes other changes in the cell. It's a physical thing. That little molecule sits there on the outside of the cell, and because it fits perfectly, it starts things off. And in the cell, what it's going to start off is dopamine. Dopamine is kind of the joy chemical. When your body starts making dopamine, you flush. If you've had a good dinner or enjoying life, you're going to flush. Well, that's coming from the dopamine triggered by your little endorphin narcotic. Well, if you take narcotics by mouth, they're going to get into those little receptors, and they're going to make you feel kind of nice, like you do after a nice dinner. But in people with abnormalities of the receptor, you put in a little opiate, which you take by mouth, and you don't get pleasure. You get 1,000 times pleasure. And that's why, if you talk to people with addiction disease, as one addicted person said to me, I don't understand why everybody doesn't do this. Doesn't shoot heroin or whatever. You can get a high from any pain medicine, but it's because there's something wrong with these little receptors. It's kind of like you jam in the little needle for the air into the basketball, and the basketball suddenly explodes because you pumped in too much air.
So this is a chemical change, though, right? Like,
it's a physical change. It's a biochemical genetic change, which they've identified. It's there, and there's no question that it's not there. And that's what's responsible. In diabetes, they haven't really nailed it down quite as well, but it's pretty well nailed down with addiction disease.
Is this in the same sense okay, like if I consume something, my body, like say if I take an opioid, my body will start making less naturally. Does that have anything to do with this or no?
It should compete, yes. And that's a good question that I don't have a good answer with yet, even though I've got it on my list of things to look up, is theoretically, if you're going to be filling up these receptors with something else, then your body's just going to get lazy, and it's not going to make its own.
Right.
So it may be that if you suddenly withdraw the opiates you're taking by mouth, it may take a while for your own endorphins to kick in. And there may be a period of time when you feel depressed, and this is reported in people who have come off their medicines. But I don't know the extent of it or any more details. But yeah, that's quite possible. So.
Okay, interesting. Are they going to do more? Is any studying or research on this right now, or do they not want it to happen because it makes money?
No, On the receptors, you mean?
Yes.
Yeah, no, there's plenty of studies. One way for your audience to find out scientific articles is to go to Google Scholar.
Okay.
Now, Google Scholar will give you more professional articles, whether it be the law or engineering or whatever. So if you put in diabetes in Google Scholar, it's going to take you to published articles in medical journals.
Okay.
Now, if you just want to find out about diabetes, you just put it in the regular Google, and then you'll get a lot of non-scientific articles, some maybe, but magazine articles, blogs, and that sort of thing. So if you put in Google Scholar, addiction, and Receptor, you should get 700 or 800 papers, which I did when I plugged it in, and I started reading them, and they're very difficult to read because they're written by these, genetic scientists, bench people we call them, people that work in labs, and figure out all this stuff. But there's several reviews. When you do that on your Google Scholar, you can put in addiction and receptors, and then put in the word review.
Okay.
And you can get reviews and read them. Even NIH says that there's no question that addiction disease is a genetic malformation of these receptors.
Interesting. Do you know if PubMed is also a good place to look at different?
Yes, PubMed is kind of where you're going to end up when you put in things in Google Scholar.
Okay.
So you can do it either way.
Okay.
Yeah, PubMed is the official website for the National Library of Medicine.
All right. I know we once were talking about urinary drug testing, and you were saying that there was something and you told me, I think, to look up in PubMed of how it could be a possible another testing to be able to see if the body how much an opioid will be within the body, or do you remember with the saliva, was it?
Not offhand.
Oh, okay.
But I can tell you I totally disagree with urine drug testing.
Okay.
And there's about 200 reasons, and I think your next guest, Dr. Fudin, will be talking about that. These were tests that were used in addiction clinics. Addiction clinics are tough because you're dealing with people with a very tough disease. And so people, because they're not being given the proper medicines, tend to become manipulative, and, they're trying to work the system and blah, blah, blah. So urine testing was invented in addiction clinics. There's about 1 million addicted people in the United States. There's 10 million people with serious disease taking the same medicines, only they're being restricted. So why do testing that you would do in an addiction clinic in a pain medicine clinic?
Right.
There's just no reason. The false positives, people are kicked out of the practice. It goes on the national computer. Oh, he's a red flagged drug seeker. The rest of your life, you're not going to be able to get pain medicine. You go in for surgery or something, it'll flash up on your computer. It's like having a little thing around your neck with an A on it.
Right.
Well,
our 30 minutes went by really quickly. Did you have any last words for us for this evening?
No. But feel free to, call into the show, and we'll discuss anything. There's nothing that I'm not willing to have a discussion about, and I try to be not, as a lot of people are, highly opinionated and poorly informed. So at least I like to talk about things I know something about, and so there are things I do not know anything about, and I will not discuss them.
Okay. Sounds great. Well, thank you so much, Dr. Kline, for joining us this evening, and we will see you next Tuesday.
Thank you very much.
Have a good one. All right, everyone. At 8/7 Central, we'll be back here with Dr. Jeff Fudin to talk about urinary drug tests. Sorry. Thank you, everyone on YouTube. Come back in 30 minutes, and also please listen in through our streaming network. We'll see you in about 30.
You've been listening to The Doctor's Corner with Dr. Kline and Janelle Elgway. Copyright 2018 by EXG LLC. All rights reserved.